There we go. Okay. So go back to this. There we go. Okay. Well, here we go. Welcome, everyone. I hope you've had a great week. Um, we are going to dive right into week two. The biggest thing I wanted to let you know before we get beginning, there were some folks that misread the syllabus. And so if you happen to miss the quizzes are always due on Sundays. I did reopen it. So it is open through 11:59 p.m. Eastern Standard Time tonight. As with any quizzes, if you have ever had an issue with going through and so you start a quiz and let's say you're out west or something in a different time zone, be very cognizant that e-learning is in Eastern Standard Time. So don't start a quiz with 5 minutes left and be like, oh my gosh, because you will only have like 5 minutes left to go, because it will cut it right off at that 11:59. So just to give you guys a heads up on that. So anyway, just to let you know, that's been taken care of. I did get that open. I hope it worked appropriately. If that is something you need, this is kind of my one time. Somebody used the word mulligan. I laughed. That was the best line ever. I'm not a big golfer, but here we go. Okay, Gwen.
Dr. Johnson, I'm sorry, I'm a little confused. It's saying quiz one isn't due until September 26th. So what quiz are you referring to?
Is that what it says online? Are you looking on the e-learning website?
Yeah, it says Blur 2, quiz 1. Am I in the wrong? Oh, maybe I'm in the wrong section. I'm sorry. So I should be in.
Sorry, I
Oh,
lost
I
my
see.
connection.
So it's
I
the I and How It Works quiz.
Yes, there's iWorks one, quiz one, and iWorks quiz two.
So only the one that's the I and How It Works quiz one is due tonight.
Right. And then the quiz two will be due whatever day next Sunday is. I'm trying to pull up a calendar, which would be the 22nd.
Yeah, I did the same thing. I just looked on the front page and it says I quiz due. That's totally, I did the exact same thing. If you look on like the page, you know what I mean? Like if you just go to like the course homepage.
Is this in e-learning you're talking about?
Yeah, so like if you just look on the content page and you open up like where it says syllabus intro, it says introductions available not September 9th, and then it says exam one starts September 21st. I opened my page up on Saturday to ensure that I didn't miss anything, and I saw that it said September 21st, exam one, and then I'm like, okay, I don't have anything due. And
Okay.
clearly I
Right.
missed it. And it says midterm part one.
And
in October.
honestly, no worries on that. I'm not 100% sure how those actually show up there. So I'm sorry about that. But yeah, anyway, just that's why I wanted to make sure we talked about it tonight. And I want to give everybody ample opportunity to make sure they had that to happen.
So in the future, we should actually go to the assessment page in e-learning to know when our assignments are due.
I will also, oh my gosh, I feel like I'm having connectivity issues tonight, so I apologize. I will make sure that I'm putting it in the intro part of the course modules. I will update all of those quizzes. So if you go into the actual module, it'll be like, okay, this is what's due. Just to kind of make it a little bit more simpler.
I also wanted to throw in that the calendar feature on the right-hand side of the e-learning has the dates for everything, so that's extremely helpful.
Is that Oh, so like in the homepage of e-learning, that's where you're talking about?
Yeah, it'll have like upcoming events, so like, our topic submission was on there, the quiz is on there, like it's all listed on the right-hand side. It's
Okay.
really helpful.
That's where I was hoping it was. I'm not good at how to find the student view for me to view how you guys do it. So I really hope I try to put as much information to try to keep it as simple and, keep you guys up to date. Cause I know, you guys are working, you have multiple classes and things like that. So, and God knows I need it easy for myself here. So anywho, so anyway, if you had that issue, it is open until this evening, and just make sure you get it done. Because again, we do drop the lowest 2 quizzes, but those do become extra credit points. So you just want to try to complete everything if you can. All righty. So let's move on. We're going to talk about week 2. So I'm going to start us off talking about abbreviations because, again, there's going to be a lot of abbreviations you may see in this course. And from this point onward, if you want to use them, feel free. I just ask that you obviously know what they, somewhat mean here. So abbreviations, basically with anything in medical, it's based out of Latin. So forgive me. But if you see if you want to talk about the patient's right eye or the client's right eye, it is oculus dexter, which shorthand is OD. Left eye, oculus sinister, is OS. Both eyes is oculus uterque, which is OU. So that's the big things. OD, OS, OU are the biggest ones you will absolutely see. If you see any eyeglass prescription or contact lens prescription, you will always see OD, OS written in there. So that is definitely one of those things that you just need to know. Might see that for pro re nata. I lost. Sorry, I'm having technical issues. I hope you guys are still connected. Hold on just a second here. Can somebody just give me a thumbs up that you guys can still hear me? Thank you. Okay. I appreciate it. I'm using my laptop and I have no idea why this is great tonight. Gotta love everything here. So anyway, I will be posting the transcripts. Hopefully those come through loud and clear here. The term immediately is statum, and that is short for stat. GTTS stands for Goutte, which is eye drops. SX. Now, SX can be a little different. I don't have it on the slide. SX you may see for surgery, or it may stand for symptoms. It just depends. So gotta love that part here. And then diagnosis will be DX, and that's you might see for diagnosis. So anyway, just to kind of let you guys know, these are some certain things that you may have to use. So let's go back into alignment. We kind of ended last week with talking about all of the different eye muscles, and this is where we're going to talk about the rectus muscles and the oblique muscles a little bit more, but we're going to kind of build on that part here. So how do they work together? So again, in a perfect world, we have 2 eyeballs that can see and should point into one spot. So you get one image. The brain doesn't like to see 2 images. It will get confused. So it's a very delicate balance on how to aim all 12 eye muscles, 6 from one eye, 6 from the other, to get that eyeball pointed. So the macula itself is pointed at the direction it's actually needed. So it's a very, very delicate balance in order to create fusion. Again, this term fusion means you have 2 eyes that give one image. Now, when we have binocular vision, that is literally the ability of the ability to fuse the eyes into 2 images into one image. It's a very much a balance of motor. Motor function basically is the eyeballs moving to aim at the same direction. And then the sensory function, the eyes actually seeing and providing the visual information to the brain so the muscles actually know how to move. So they have to work together. So you have to make sure there's equal impulses coming from each eye. It really works if you're seeing the same from both eyes. And then you have the contraction of one muscle is equivalent to the relaxation of the opposing muscle. What in the heck does that mean? Oh my gosh. Something my son was saying. What the heck does that mean, Papa? Anyway, when you have the contraction, so let's say the lateral rectus is pulling the eyeball outwards, the medial rectus needs to relax so it doesn't pull at the same time. So, the medial rectus has to relax to move, for example, the left eye to the left. And the medial rectus, because if the medial rectus was contracting at the same time that the lateral rectus was contracting, it would literally just pull the eye backwards. Well, that's a big no-no. We can't do that. So therefore, we have the contraction of one muscle that's opposite, the other one has to be relaxing in order that to happen. Then we can have what's called suppression. And that's basically the brain doesn't like to be confused. And so seeing double makes you confused. And so therefore, a clear image along with a blurred image cannot be fused because, again, we want to have that same equal input from the both eyes. So suppression is literally the ignoring of that blurred image. We're not going to talk too much about that. That really gets into pediatrics and lazy eyes and things like that. I'm not going to really focus on that course. But that's really how, you can develop a lazy eye as a child because you've got a blurred image and a cleared image, and the brain just cannot put the two together. So when our eyes are aligned and are looking at something, we have the ability to see more with two eyes than just one. In fact, 35 degrees of a client's vision is overlap. And they use this overlap to merge the peripheral vision. So it's kind of like a puzzle piece. We got to get the peripheral part because, again, we don't have those cones in the periphery. We just have the rods, which are not that high detailed vision. And then therefore, if we can lock in, okay, the peripheral visions, so whatever we have on the outside of our vision, we can lock that together. And then therefore, our eyes are going to be pointing in the same direction because now we've put the two eyes together as a puzzle piece and we're now locked in and not seeing double. So in a perfect world, we would fixate at something that would be looking straight ahead. In order to fixate on something and stare at like a tree or your child's face or this lecture, you have to have good stability with your eyes so they can't be shaking, and they have to have good monocular function. So they have to work independently. That is going to help them ideally work together. So any different things, we'll talk about all these, but nystagmus, macular disease, strabismus, all of those can make things go wonky, and therefore it breaks down the ability for the two eyes to fixate together. So again, just to kind of talk about a little bit, since we're talking about eye muscles, the term strabismus is the misalignment of the two eyes where they're not pointing in the same direction. When the two eyes are not pointing in the same direction, you would see double because the maculas are not pointed at the same spot. And therefore, when we call the term double, the technical medical term for that is called diplopia. And again, our brain wants to avoid confusion. So therefore, if there is an eye that's pointed outward, it's going to pick one and go with that. And that's going to be ultimately the stronger eye, and the other eye becomes a lazy eye. And that's where the term amblyopia comes in. So amblyopia is, the layman's term is basically lazy eye. But again, that is why it happens. So, we don't see double. And I'm going to have you ignore the other parts about eccentric viewing. That's something I'm not going to get into. So we're just going to stop that slide there, but we will continue on to fusion. Fusion now is the effort exerted by both eyes to keep the position aligned so that both fovea project to the same place in space. So when we have fixation, that's just one eye. But when we have fusion, that is both eyes fixating together and keeping so the both foveas themselves or the macular region are all pointed at the same exact direction. So fusion is disrupted by covering an eye, because basically if you cover an eye, you're now just fixating. They're not working together anymore because you're blocking one of the eyes. So we all have what's called this fusion-free position. And so this is where we have heterophoria. And basically, you know, the two eyes aren't normally made to just be looking in the distance straight ahead. They have a resting place. And so every time you blink, your eyes go into that resting place, and then they're instantly now looking wherever you're fixating. So we can talk about that with esophoria, exophoria, hyperphoria. If you see the term esophoria, it basically just means that the eyes are turned inward a little bit. The resting position is towards the nose. Exophoria is toward outside, it's towards the ears. And then hyperphoria, you have one eye that's a little bit above the other eye. I have students that ask, well, what happens if you have both eyes that are, you know, just slightly elevated? Well, basically, I hate to put it this simply, it's just one eye's looking up, or they're just looking up. Because if both eyes are looking upward, they're both just looking up. So you can't have them positioned that way. One has to be higher than the other to have the term hyperphoria. We do this by measuring with prisms. We'll talk about prisms a little bit when it comes to the optics section. But when I talk about normal convergence, all is I want, you do not have to memorize these numbers, but normal convergence, if you have ever tried to cross your eyes, and this would be where you move both eyes towards the nose, you are using the medial recti because it's the medial rectus is pulling the eyes towards the nose. And when they move towards the nose, that is called convergence. And we can converge a lot more than we can move our eyes outward. So basically the normal area of convergence is 20 to 40 diopters. So 40 diopters, think of that as going all the way to the nose, where you literally, if you're following an object into your nose, you almost could basically touch your nose and bring your eyes in. It hurts. Don't get me wrong, those muscles aren't used to being strained that much, but convergence gives us the magic of reading. It's how we look at things up close. So that's what convergence does. Divergence is the opposite. That's moving your eyes outward. Well, we can't move our eyes outward as much, and so you can see it's basically half of what we can converge. And when we have a vertical imbalance, it's only a slight imbalance between the two eyes that can cause double vision. So that's to kind of give you hopefully just a little bit of an idea. So again, our eyes are able to work together, and they can diverge, they can converge. So diverge is moving outwards, convergence is moving inwards. They just don't like vertical imbalance because it makes things wonky and makes you dizzy, and it's not fun. So we're going to talk next about eye movements, so you kind of get an idea how the eyes actually work together and come together here. So there's three basic positions or positions of gaze here. So in the primary position, if you hear somebody say the primary position, it is literally looking your eyes straight ahead. There's nothing fancy about it. It is just your eyes looking straight ahead. Now, in a secondary position, this is moving your eyes up or down or left or right. So it's a horizontal or vertical movement. In a tertiary movement or tertiary position of gaze, this is an oblique movement. You're like, what the heck does an oblique? Yes, it absolutely uses the oblique muscles if you were thinking about it. But the best way to use it is if I tell my 4-year-old something he doesn't want to do and he rolls his eyes. He's already pretty much an expert. I swear this is an innate ability of any kids anywhere to roll their eyes at their parents. So anyway, a tertiary position is an eye roll. You may be doing this at me right now. I have no idea. I can't see you. But that would be a tertiary position. We also have some movements. There's the two term, if you see adduction, this is literally one eye moving from one position to the other. And then a version, on the other hand, is a moving of the two eyes together in the same direction. So you can have adduction, that's just one eye moving, that's the key to this one. And then aversion is both eyes moving. So you may think it's a nuance, but this is how it can actually test the eyes. So adduction, just one eye, version is two eyes moving in the same direction. So another way of thinking of this, hopefully this kind of helps out a little bit. We have the lateral rectus, for example. It moves the eye horizontally from the nose, so towards the ear. That is abduction. It is abducting the eye away from the nose. I don't know, however you want to remember this. Then we have the medial rectus that moves the eye towards the nose. It is adduction, or there's two D's in it. If that helps you, I don't know. And then, we have some of the auxiliary functions. It just shows that auxiliary functions, when you roll the eyes or in those tertiary positions, you actually are going to use more than one muscle. I'm not going to get in the nitty gritty. As far as I know, they're never going to ask you this on one of the certification exams. So I'm not going to confuse you. But just know if you roll the eyes through intorsion, which is again rolling it towards the nose, or extorsion, rolling it away from the nose, you're going to use a couple muscles, and it's basically like rolling your eyes. So again, I just have another chart literally of summarizing what the eyes do. Again, that medial rectus turns the eye towards the nose. The lateral rectus turns the eye outward towards the temples or the ears. The superior rectus moves the eye upward. The inferior rectus depresses or moves the eye downward. The superior oblique in towards the eye, and then the inferior oblique X towards the eye. Then there's some secondary things and everything like that. I'm not going to ask you directly the rectus muscles. Yeah, I may ask you. You may see potentially, what eye muscle might cause an eye roll, and it literally would be an oblique muscle. I'm not going to get any more specific than that. And again, this is recorded, so you can hold me to it. So there we go. So when we talk about other movements, where do they come from? So we have volition. These are rapid, high-speed movements of the eyes that end abruptly. So let's say you just quickly move your eyes left to right. That's a volition. Because vision really doesn't happen through that part, the world just whizzes by. It's not like you're focusing on anything. It actually happens from the frontal lobe of the brain. So in the cerebrum, right up here in the front, that is where the volition happens. It ends abruptly. It's a quick eye turn, left to right, up, down, whatever. That's called volition. Now, if you pursue something, so, we think of I'm really aging myself, but for example, the O.J. Simpson case where the chopper was following the SUV, that was a pursuit. So you're watching something move. So therefore, it's a much slower process. So you can actually see what's actually moving. It's a slow, smooth gliding where your eyes are only moving less than 30 degrees per second. So it's very, very slow. And yes, we're talking about the same degrees from geometry of a circle. So it's a very, very slow movement. So you can actually watch, you're getting the visual information of this moving object that is ultimately moving, I guess, for lack of better words to end it. So volition, high speed of movement of your eyes from one point to the other. You're not getting visual information in between. That comes from the frontal lobe of the brain. And then pursuit is from the occipital lobe, which again, as we talked about last week, is in the back of the brain and the back of the cerebrum. And that's where the visual cortex is, but you're actually getting the visual information as you're watching something, whether you're watching an airplane way off in the distance, your eyes are moving and kind of following it. It's a very slow, methodical pursuit here. So when we talk about near objects in movement, this is called vergence. So it's the simultaneous ocular movements in which the eyes are directed to an object in the midline in the front of the face. So therefore, vergence deals with the eyes moving horizontally, whether it's towards the nose or away from the nose. That's what avergence is. So in convergence, there are three. That's three. If you get to 3 days to kiss the prince, you have convergence. So convergence, there's three things. The eyes will rotate inward. You will have the constriction of the pupils, so you get that sphincter action moving, and then the lens itself will accommodate to bring anything up close onto the retina. So there's three things that happen in the convergence. We call that the accommodative triad. So the eyes rotate inward, you have the constriction of pupils, and then you also have accommodation. Now, with divergence, basically the opposite three things happen. So the eyes move outward. So the eyes were moved inward. That's what happens when you read, you look at your phone, anything up close, anything ideally closer than 20 feet. We'll talk about why that actually happens. But basically, these things have to happen for you in order to focus up close. So again, the eyes rotate inwards, you have the constriction of the pupils, and then you have accommodation. In divergence, they move outwards. You know, the pupils will obviously enlarge in because they're not having to focus. So the constriction of the pupils do give focusing ability. And then again, your lens goes to relaxation to look in the distance. So looking at the accommodative triad just a little bit closer, the whole point of convergence is to, alleviate diplopia. You don't want to have double vision. It moves the eye towards a close object. Because if you look in the distance, but you hold a pen in front of your face, you see two because your eyes are not focused on the pen. So once your eyes focus on the pen, you see single, and you've started the whole accommodative triad. So with convergence, that's the part of the eyes moving inward, and it moves the eye towards the object. With pupillary constriction, it forms a pinhole. Remember, the iris is like an aperture of a camera. So therefore, it helps bring things into focus and gets out the little natural blur that we may have because we don't have perfect prescriptions. And then accommodation actually brings the object on the retina. So again, the hard part is it synkinesis versus a true reflex? Like, does it automatically happen? Do we force it to happen? What actually makes this happen? In the big stimulus to the accommodative triad, or to make the eyes focus on something up close, is literally a blurred object on the retina. That is what directly happens that makes the convergence or the accommodative triad actually happen and going in. So therefore, hopefully that helps out a little bit. So depth perception. In order to have depth perception, that is one of the amazing things that really does help us humans interact with our surroundings, that the two eyes literally have the ability to work together. The nice part is, yes, we do have the ability to judge distances, and this is because of depth perception. So we can do that in different ways. We can use monocular clues. So basically, if you only have one functioning eye, you can still have depth perception. No, it is not as good as having two eyes, but it can still work. So you can have magnification just by simply looking at, okay, these are two similar objects. I know they should be the similar size. So your brain intuitively lets you know that the larger one is going to be closer to you. The further away things get, the smaller things look. You can also have the confluence of parallel lines. The confluence of parallel lines basically is straight lines look like they're kind of getting closer together the further away things are. So that kind of tells you, okay, if like a road, doesn't stop at a pinpoint or anything, that it's actually going away from you simply because the road seems to get narrower the further away it gets. You can also have the interposition of shadows. Just by looking at shadows kind of lets you know, okay, this shadow is bigger than the other one. That can definitely let you know. Again, these aren't perfect, but again, they're better than nothing. And again, we utilize our natural senses to kind of understand these through life's experiences. We also know that there can be a blue-gray mistiness of objects at greater distance because it's a little fuzzier, it's a little harder to see. And then parallax is basically just simply looking at the movement of one object. So if you are lining up trees and you're looking at one tree, it's going to, you can shake your head back and forth to see what other objects are doing around it to kind of get an idea, okay, what is in front, what's behind, and things to that nature. Again, not going to go into specifics about these, but just knowing that there's different ways of having depth perception without having two eyes. Now, when we talk about stereopsis, this is the higher quality binocular vision. And we have stereopsis because the two eyes aren't getting an identical image. We have two eyes that are separated by a nose. And again, not making fun of anybody, but some of our noses are not equal sizes. I mean, look at Steve Carell, for example. He's got a really big nose. And so therefore, his depth perception has to be amazing. I don't know. And please do not send him this video that I'm talking about him. However, the further apart the eyes are, the more depth perception is going to have because there's a slight different angle between how the eyes are focused on something, and it actually gives you better depth perception. So therefore, with stereopsis, the fusion occurs because they're slightly dissimilar images, and then that being that they're not the exact same images hitting the brain, therefore you can get depth perception. So I have this little picture here that's a pretty remarkable. And if you do have depth perception, it's a little circles with different colors and everything like that, but it will literally look, your eyes will play tricks on you like this picture is actually moving. And again, it's little spirals and things like that. And again, we know I didn't put a GIF in here or something like that that is going to, move automatically. It's literally a stationary flat picture, but if you have depth perception, it makes things move. These are no different than those 3D Magic Eye books that were really popular. I'm dating myself, back in the 90s. That might have been the 80s. I don't even know. But again, it's one of those things that are really out there. At least somebody knows what I'm talking about here. So thank God. Okay. So when we talk about accommodation, this is the range of focus. So yes, going back to somebody saying I had no idea, if you don't have stereopsis where the two eyes don't work together, you cannot do it. And this is how 3D movies are created. They basically make the two eyes work a little bit more independently of each other. So therefore they're getting a bigger image to make the screen look like it's coming out at you. So anyway, there's that. So with accommodation.
Okay, just hold on one quick second. So somebody
yes.
who struggles with this can see the 3D or can't see it?
So with somebody that cannot see 3D, the two eyes are not working together.
Okay, so somebody with strabismus, is that how you say it?
Strabismus, yes.
Strabismus, they don't have depth perception, so therefore a 3D movie would not be something they would benefit from.
No, they'd actually probably get a headache from it.
Okay.
Because honestly, it's going to look blurry. And that's where there's a lot of testing out there. So if, like any new pediatric patient that I see, generally if they're under 18, if it's the first time, I'm going to do a stereo test just so I can see, are their two eyes working together? Is there something I can do to put them together because of prescription or anything like that? So there's going to be, different testing that we can do. But it really does let us know. So if you went to your eye doctor and used the fly test, for example, where, you put these 3D glasses on and you see, does the fly look like it's sticking out at you? It's literally, it's a quick and dirty way of being like, okay, do we have depth perception or not? So it's really helpful. Now, when I say they don't have depth perception, I just mean stereopsis, where the two eyes are going together. We have that innate ability to still use the monocular depth perception cues, but it's just not going to be as good. And those can be really hard to learn. And the reason I bring it up is, for example, if you've lost vision as an adult, where you've had this stereopsis, the two eyes working together to give you depth your whole life, it's really hard to look through because now all of a sudden steps look flat, curbs look flat. So this is where orientation and mobility is so incredibly important, potentially, or, getting somebody to use a support cane even too. I mean, all of these things are why that's so incredibly important. Hopefully that helps a little bit. So with accommodation, this is again how the eyes focus. So we have a range of focus, the ability for our eyes to go in, focus from the distance all the way to up close. And so basically at 20 feet, our lens does not need to work. Our lens can be totally relaxed at 20 feet, or if we're anywhere else in the world, 6 meters. So the range of accommodation stands for the distance an object can be carried to the eye and kept in focus. So it's continual readjustment. At 7 years old, you can hold something right to your face and you can see it. But my son tried to do that to me this weekend, and I'm like, oh my God, get it away, because I'm in my 40s and therefore can't hold it that close. That range of focus is moving away from me. And so the power of accommodation, you can measure that, and you have the dioptric equivalent to that distance. We measure diopters for, again, the distance of the curvature of what is actually focusing on the eye. And again, we'll talk about that more in optics. So what is accommodation? Again, what makes accommodation happen? The stimulus is a blurred image on the retina. So if something's blurry on the retina, it is going to trigger the accommodation system to bring that into focus. So as an object moves to the eye, the light must be converged or brought inward towards the eye. Therefore, you get the contraction of the ciliary muscle that allows the zonular fibers to relax, and therefore the lens changes shape. So again, we can get a measurement to find that closest point of an accommodative target. The reason we talk about that is because of magnifiers and everything like that. So therefore, you can actually literally measure that. So therefore, again, that blurred image on the retina, that is the stimulus to make the accommodative triad happen. So our lens will focus when there's a blurred image. So next up, this is where we get into the whole review of everything and hopefully go from there. Hopefully this helps you out a little bit and lets you understand. So there is the transparent pathway of light. If you ever happen to see what are the 6 structures that lead to the transparent pathway of light, here they are. We have tears, the cornea, aqueous humor, the iris, the lens, the vitreous body. And you're like, whoa, hold on. The iris is opaque. That's true. However, there's a hole in the middle called the pupil, and that's why the iris is part of the transparent pathway of light. So as light enters the eyes, there are 6 parts that it goes through before it hits the retina, and all parts of those are transparent, and they must maintain transparency in order for light to hit through them. Again, we'll talk about all this on how that works in our optics section, but again, it's very important for the light rays to enter our eyes that way. So in the transparent pathway of light, as I said, you must have clear media. When I say clear media, I'm not talking about television, social media, anything like that. I'm talking about the organs that was part of the eyeball organ. It's got to go through it clearly. Otherwise, if it's clear, it's going to block the light. You're not going to get a clear image. And so the primary function of the eye, if you want to think, what does the eyeball do? Does it see? No. It is maintaining a clear pathway for light rays to enter the eye for the brain to ultimately process the image for us to see. So I call it the prime function of the eye is literally maintenance of the transparent pathway of light. So let's go back. This is where we get into a little bit of review. Going to talk about a lot of the terminology we used last week and everything like that. With the tears, that is the first part that the organic part of the eye that light is going to go through. And again, there's 3 main layers. There is the oil or lipid layer. This is the fatty layer. It's the outermost layer. It comes from the meibomian glands. Those are glands in the lower and upper lids that everybody's clogged now because we stare at screens all the time. And these glands are so important because they prevent the tears from evaporating off the eye. That's why they're oily, they're lipidy. So yes, they're fatty, but again, the thicker they are, that prevents them from evaporating off the eye. Then we have the aqueous. That's kind of the middle layer of the tear film. And that comes from the lacrimal gland, also some glands. There's some sidekick glands in the conjunctiva. But the lacrimal gland is on the temporal part, the outer part of the eye, right above that outer corner of the eye. And it's made of inorganic matter and salts, as well as a lot of water. That's the biggest part of the tear film. Then we have the mucin layer. Believe it or not, the eyes, as much as they need to maintain a moisturized environment, the eyes try to repel water. It's the craziest thing. So the mucin layer is so unique because it helps the tears actually stick to the eye. And it also helps hold out those tiny irregularities within the cornea. Again, the cornea is not a totally smooth surface. So therefore, you get these tiny irregularities. This helps the tears actually go through it. I know we think of oil, water, mucus. Gosh, that sounds like a lovely combination, says no one ever. But again, it's all incredibly important to make our tears work. So yes, it's a lovely combination. Instead of lions, tigers, and bears, it's oil, water, and mucus. Oh my! Anyway. So we basically produce about 0.5 to 1 milliliter of tears produced daily. 50% of those do evaporate. The other 50% do go through the nasal, through that inferior and superior puncta into the nasal lacrimal duct, and then into the inferior meatus of the nose. So the inferior meatus of the nose is just the opening that my 4-year-old loves to pick because I can't keep his fingers out of his nose. Anyway, there's also lysozymes. I'm sorry, he will kill me someday. I know this, and it's fine. It's fine. Anyway, then they also have lysozymes. These are non-pathogenic bacteria in there. And then how the tears actually form. If we actually think about tears, when tears are streaming down our face, there can be a psychic part that, caused by emotion, or there can be reflex, very uncomfortable retinal stimulation. I guarantee I make this happen every day when I dilate my patients and shine bright lights so I can view the back of their eyes. So there can be reflex or there can be psychic that can produce obviously more than that 0.5 to 1 milliliter of tears. Next up, we have the cornea. The cornea, again, has 5 layers. There is a cell and collagen fiber arrangement that has to be just so to keep that baby clear. And again, there needs to be minimum diffraction and internal reflection. Well, geez, I'm going to throw my pen. What the heck is that talking about? Well, basically, you want the light to go straight through all 5 of those layers. You want the cornea to bend the light so it actually starts moving towards the retina and aiming and bringing the image onto focus. But you don't want it to hit light to scatter and make an unclear image. So therefore, is there edema? Is there, if you don't want to have edema is swelling. So that can cause that cell and collagen fiber arrangement to be distorted. You also don't want opaque substances. Hold on, I saw that there's a question coming through here. So I just thought of a question. Are there any eye diseases we will study that have to do with defective tears? Believe it or not, pretty much any eye disease causes defective tears. And to make it even more fun, wait for it. You guys know we're in a nation that loves its pharmacology. So we prescribe pills like nobody's business, or we pop pills because that's, I guess, what we do as Americans. We just want things gone immediately. We don't want to work through our emotions. We just want to take, anyway, just kidding. Mental health is a real thing. I'm not making fun of that. Please know that. But we just don't want to have to try to do our work like high blood pressure. Nope. Well, we're not going to work out. I'm just going to sit in the couch and eat Cheetos. Anyway, just kidding. So basically any type of side effect of most of our drugs create dry eyes. So all of this creates defective tears. So isn't that lovely? But yeah, we could do an emo band name. Oh my gosh, I love it. Okay, so nourishment. We have the perilimbal blood vessels. These are that limbus area. That's the area where the conjunctiva meets the cornea. So that circular area around the cornea. The cornea also gets nourishment from the tear film. And then obviously non-defective tears gets the nourishment there. And then the aqueous humor. So inside the eye itself does nourish the cornea. Okay, so we have dehydration. Believe it or not, the cornea obviously is hydrated. The sclera is not. That's the only difference. If you look at the cellular makeup of the sclera versus the cornea, the sclera is dehydrated. I just thought that's a fun factoid. So then we have the corneal epithelium and endothelium. Those are the epithelium, that's the outer part towards the environment. The endothelium is inside. The epithelium protects us because it's fast regenerating. So it really protects from scarring because their nerves are exposed. So if you scratch something, you're going to try to get it out immediately. And then the endothelium is so incredibly important because that's the dam. That's what creates the homeostasis of the correct part of water in the eye. So therefore, the right amount of water goes in and out. So the only parts, and I have this part about regeneration, only really the corneal epithelium can regenerate. I mean, they all can regenerate, but you'll have scarring in anything else but the epithelium. The Bowman's layer and stroma can also regenerate. Anything below with decimase or the endothelium, those cannot regenerate. When they're gone or damaged, they're gone. That's permanent, gone for life. So again, epithelium, Bowman's layer, stroma. That's why we can do LASIK surgery or laser correction surgery on folks, because again, that stroma does regenerate. Yes, you absolutely see scarring on it when you do laser surgery, even years later. I had mine done 14 years ago. And yes, you can still barely see my laser scars, but that's because they're so good at doing it now. Come on, here we go. Come on, slide. Pick up. There we go. Okay. Next up, after the cornea, we have the aqueous humor. This is the fluid that is between the cornea and the lens. It is clear, colorless, and watery, and it is formed in the ciliary processes just behind the iris on the outer part, flanking it, and it is in constant circulation. So, it's being formed by the ciliary processes, and then, or the ciliary body, and then it moves through the iris, hangs out, dances around in the area, nourishes the cornea, and then goes out through the trabecular meshwork. So again, the formation, it starts in the posterior chamber in the ciliary body. So it's, again, the posterior chamber is anything behind the iris or towards the retina. And then it is between the retina between the lens and the iris, flows through the pupil, goes into the anterior chamber, the part of the lens or the part of the eye between the iris and the cornea. Then as it exits, it goes through the trabecular meshwork, through Schlemm's canal, into the aqueous veins. Then we go and becomes back to blood, because again, aqueous is formed from blood and goes back to blood. So it sounds like, I don't know, some type of poem or something, I guess you could make up. So again, when we talk about intraocular pressure, it is the aqueous humor that affects intraocular pressure. So just like we have blood pressure, we have that internal eye pressure. The vitreous is actually non-movement. And again, just because the question just came up, I think you covered this, but we're floaters developed by collagen cells in the vitreous humor, actually, not the aqueous humor. So the vitreous humor is it's just inert. It is there. It doesn't change from life, but it just does liquefy over time. That causes the collagen fibers of the vitreous to lose. So therefore, we're talking about the aqueous humor when it comes about eye pressure. And that eye pressure is generally between 13 to 20 milligrams of mercury. Again, not related to blood pressure at all. And so, we have problems when it's either too high. We call it ocular hypertension. Again, you can have high blood pressure without having high eye pressure. They are completely not related. But you can even have problems when the eye pressure is lower. So that's why it's important to have an eye exam from a professional that actually knows what the heck they're doing. So there can be variations in eye pressure. Just from breathing alone can change your eye pressure 4 millimeters of mercury. This is where it gets crazy, but we have that central retinal artery that comes through our optic nerve in the back of the eye. So every time blood goes through it, or we have a pulse because our heart is beating, so therefore it's pushing blood throughout the entire body. can change our eye pressure 1 to 2 millimeters. Daily, we expect 2 to 3 millimeters of mercury change, and our maximum eye pressure tends to be at 6 a.m. Generally, this is really thought of because we're dehydrated at that point. I don't know what happens to third shifters or people that are up all night, and if 6 a.m. is just with our circadian rhythm. I have no idea, but at least, as far as we know, 6 a.m. is what we kind of, that would be the highest eye pressure. And the problems happen when that eye pressure high versus low throughout the day is higher, because that's what can cause damage. And that's why we have to watch everything. So again, intraocular pressure, it's very much dependent on the amount of aqueous humor. So the more aqueous humor there is in the eye, the higher the eye pressure. And the flow, or how the aqueous humor flows through the eye, is very much dependent on hydration. So if you go to an eye exam dehydrated, your eye pressure will also be higher because it can't get the aqueous out because the blood is too thick to allow the aqueous to re-enter it. Ironically, I didn't plan on drinking water at that point, but that's exactly what I'm doing. So next up, we have the iris or the pupil. I'm going to call those interchangeably together. So basically, the iris is called the shutter of the eye. Again, we compare that to the camera. Again, excessive illumination is going to activate the sphincter muscle of the iris and make it smaller to protect how much light is entering the eye. When it's dim, the dilator muscle is going to do the exact opposite, and it's going to make the pupil or the whole of the eye much bigger. So therefore, as much light as possible can enter the eye. So we're trying to pick up and use those rods because we know that the rods of the retina help us see in the dark. So basically, we have the responses. Arousal, just simply having fear, anxiety, or erotic stimulation can make the eyes dilate. So just to let you know, the pupils will change size throughout different activities you might be aroused with. And again, I didn't mean to put direct and consensual on here as well, as we're talking about erotic stimulation, so I'm sorry. But there are different things that the pupils will do, whether, what you do to one eye, you do to the others. And yes, mushrooms do have that effect on the eyes. Same with marijuana or, medical cannabis, if that's what you want to call it, whatever. Anyway, so when we have direct light coming into the one eye, the pupil of the other eye will also constrict equally if there is no problems with it. Now, we also have that consensual response. So basically, again, the light hitting the one eye having the light go in it, that is a direct response. That's going to make the pupil smaller. The consensual response is literally the other eye doing the exact same thing, even though light's not entering that eye. So the two eyes are connected. Again, if there is no type of pathology that is actually stopping the light from coming in. So the pupil is absolutely amazing. There we go. And yes, they agree, so they consent to each other. Yes, I love it, Teresa. Perfect. Okay, so next up, we have the lens. We have two parts. We have the nucleus that is formed by the age of 30, and then we also have the cortex. So the nucleus is the inner part of the lens, and then we have the cortex. Basically, when I have through here the uniform index of refraction, that means that light goes through it. No matter if it's the nucleus or the cortex, light gets bent just one way going through it. It is biconvex. Both eyes are bulging outwards. There's nothing opaque about the lens in a perfectly healthy lens. So there's nothing opaque in the lens. Believe it or not, the cornea does most of the light bending. The lens only does about a third of the light bending to focus everything. So the lens is not the heavy hitter. We think of a lens like, oh, that's what must focus everything on the retina. No, it's just mobile. The cornea does a bulk of the refraction of the eye or bending of the light rays in order to make us see. The lens is nourished by the surrounding aqueous humor. So that is how it gets its nourishment, because again, we know the aqueous is made through the ciliary processes, and then it does kind of flush the lens before it goes through the pupil. Next up, we have the vitreous body that is directly behind the lens. It is a transparent gel, and that happens to be 2/3 of the volume of the eye. It is metabolically inert, as in it is not alive at all. There's no nourishment that needs it for this area. There's nothing that's being recycled or anything like that. It's literally just a space between the film. So it's the space, we got the whole front of the eye doing the magic of refraction. And then we have this big area, and then we have the retina. So it's just space. That's literally all the vitreous is. And it's literally the shock absorber of the back of the eye, to try to absorb energy from, if you happen to take a blow or a fall, car accident, what have you, any type of trauma, the vitreous is there to kind of protect the eye. And again, the vitreous body is the last transparent structure of the eye. So let's get into the retina and talk a little bit more about the retina here. So we have both scotopic and photopic vision. In scotopic, when we talk about scotopic, this is dim illumination. We have the rods. There's 125 million of those bad little receptors there. So that is the bulk of the back of the eye. The photopic is the cones. And there are 3 colors for cones. So rods, we know 50 shades of gray. That's all you got to remember. Cones, we got to remember a little bit. There's red, green, and blue. So that is what creates all the different hues that we happen to see of color, is through the cones. And then obviously with the rods, those do add a little bit of shading and whatnot there as well. So the photopic comes from your straight ahead vision, because we know it's the foveal area, a little bit of the macular generalized area. Again, the fovea is the fine detailed part, then the macular region is surrounding it, and some cones do get mixed in there. But again, our color vision, the straight ahead fine detailed vision, is our photopic vision. Now, in order for us to fully see in the dark and let those rods completely activate, we need to actually be in the dark, complete darkness for 30 minutes. That's how we can see in the dark as good as possible. So the photopigment is actually called rhodopsin. It is known as visual purple, and it is completely destroyed by any type of light. It's also vitamin A. That's why it's important to get plenty of vitamin A in our diet as far as we know. So that's dark adaptation. Again, we got, in order to see the best we possibly can in dark, you have to sit literally in a dark room for 30 minutes. So how does the retina function? Light comes through all of those 6 transparent layers of light, or 6 transparent pathway of light. There we go. Whew, that was a hard one to get out. And then it basically hits the photoreceptors, which is on the bottom of the retina, and then everything else kind of works upwards towards the vitreous a little bit. So we have photoreceptors, then we have bipolar cells. So the bipolar cells start breaking down the excess noise in our vision to give us clearer vision, and then they go to the ganglion cells. So in the retinal synaptic zone, this is where that vision that comes from the photoreceptors starts entering and going into the nerves that take it through the axons into the optic nerve. So there's a lot of breakdown. Most of the light that our photoreceptors take in get broken down, so we get a crystal clear image. So it's amazing. It's like it's a giant computer being like, nope, you're not going to get that information, but you're going to get this information because it's going to be better, and you're going to be able to clarify this more. That's what the bipolar cells and ganglion cells are constantly, kind of fighting and breaking down to give us the crystal clear image. And again, it's a pretty crude image at that point. It's not until the visual cortex that we actually put it all together. So again, it's the axons, they go through the optic nerve. The 2 optic nerves do join together where the opposite parts of the opposite eye join. So your left field of one eye joins with like the left field of the other, or vice versa. And that happens at the chiasm. In the optic tract, that's the biggest difference between the optic nerve and the optic tract, is the optic nerve is one eye, the optic tract has visual information from both eyes. It then goes to the lateral geniculate body to the occipital lobe. Just some unique parts here. We have the retinal images. You can have positive after image. These are images that you have little awareness because the eyes are constantly moving. So even when you think your eyes are sitting still and looking at something, you have retinal images. But in order for the images to keep on sending visual information, the eyes have these microscopic movements that are very short duration, and you have little awareness. So these retinal images are constantly being refreshed and you have no idea. Now, negative after images are what you actually see, like when you have a flash from a picture or the sun gets stuck in your eyes because you accidentally looked at it, not during an eclipse, by the way. And again, it's the retinal photoreceptors generally are unresponsive because now you've used all their photopigment and they're trying to refresh. And so they're unresponsive after a high intensity of light. We can also use this, just for a quick screening for strabismus when the two eyes are misaligned, and things like that here too. Now, color vision, just to go into that a little bit and talk a little bit more about that. We have hue, saturation, and light. That is what our eyes are picking up through the photoreceptors. Black just literally adds shade. This is the good type of shade, not like Mariah Carey shade, just so we're clear here. We do have three pigments. These are not primary colors. So remember, you're going to see this a little different. We think of primary colors. I'm not going to repeat those because I want you to know red, green, and blue. Those are the three type of photopigments that the eye is the most sensitive to, and then can also utilize, because of those three pigments, of what other kind of wavelengths are coming through to see what color everything is. Now, to test color vision, we have the Ishihara color plate test. These are different plates that literally have different numbers mixed in through different colored circles throughout that would make up a number if you don't have a color vision problem. And again, about 8 to 10% of males are colorblind, less than 0.1%. I think my little point fell off of there, but that's how small percentage. It's a very rare. I think in my 17 and a half years of practicing, I may have seen one colorblind female. It's so incredibly rare. And mind you, I see, oh good God, 3,000 patients a year. So anyway, it's a lot. So, there's different things. You can have a partial deficiency of one cone pigment. That's what really causes color blindness, and everything like that. I'm not going to go into the trichromat or anything like that here. But you might see proton anomaly. It's really easy to pronounce, let me tell you. Or deuter anomaly. So proton anomaly is deficiency to red. That is poor red, green, blue, green discrimination. Deuter anomaly is deficiency to green. So you have, excuse me, poor green, purple, and red, purple discrimination. You can also have different types of a dichromat where instead of having just a partial one of the color photopigments here, it is you only have two pigments in a dichromat. So therefore, that's kind of where it is. So protanopia it does not have the red color, the photoreceptor. Deuteranopia does not have the green, and tritanopia does not have the blue. Again, I'm not going to go into the specifics on any testing. Kimmy just asked a great question. Is there any research around why females tend to not have color blindness? So we're going to get into genetics for 2 seconds, but I'm going to try to keep this as simple as possible. What makes a male is the XY chromosome. What makes a female is the XX chromosome. Color vision of having all three perfect the perfect color vision is on the X chromosome. That X chromosome comes from the mom, the dad sends the Y. So if the it's just much more, it's much easier to have it line up where if you just have an X that has the color deficiency on it, it's going to be a male. That's just how it is. And the mom sends it. However, if it's a female, both X's have to have that color deficiency. So therefore, the odds are much more in the favor that they're going to have the dad's probably going to send an X that doesn't have color vision, because otherwise the color vision is going to be there. So therefore, it's all about the XXXY. It's on the sex chromosomes. That's as far, hopefully I'm not even confusing you, but it comes down to the XX and XY chromosomes. Hopefully that helps, Kimmy. So again, the last one is literally, I have a slide if you are visual at all and able to make this out. Again, it's not like something I would put on a test, but again, it shows what a normal color vision would look like versus a protanope, deuteranope, or tritanope, where you're missing some of those color pigments, so you're not able to see what number is being colorful and kind of being displayed in this color vision plate, as we call it here. So next up, we have a study session that'll be this Friday. It is going to be at 8:30 p.m. live here on WebEx. Don't be so excited because it's a Friday night. I have no idea how it's going to go because basically you control it. I'm just here. I'm going to just kind of hang out for about a half hour or so. It may be longer if you guys are asking great questions and everything. It's going to be recorded. There's nothing that will be quizzed directly that comes out. So if you just have a random question that you're like, I don't want to ask this in class, that's kind of the time to also do it. But also, kind of be mindful if there's other people showing up that want to ask good questions, that's exactly what it's there for. Exam 1 becomes available September 21st and then ends on the 24th. And so therefore, that's when you have to take it. So just go into e-learning, make sure you take it. And then September 22nd, Module 1 discussion and iWorks Quiz 2 is due. So hopefully that helps you out with some dates there by putting that ahead. Exam 1, just to let you know, you have 40 minutes to take it. There's 28 questions. There'll be 10 multiple choice, 10 true false, and 8 short answer. And so just be complete, any type of short answer. I just want completeness. And again, I just give 40 minutes because again, I don't want you to have to look things up. I'm hoping you don't have to look, things up, but again, you will still have 40 minutes to complete the test here. So hopefully that helps. I am going to go ahead and stop screen sharing. So if you have any questions, we can hopefully answer those now. So I know it's a lot of information. I will get this posted again tonight before I go to bed because I want to make sure you guys all have this. I don't think you'd be listening to it tonight. God knows I wouldn't want to listen to myself a second time today. Question that came up, are you going to email us individually about our topic selections? They have all been graded, so they should all be, if you look into e-learning and you go on to grades in the comment section, that is where they should be. So I went through, so if you uploaded, they are there. Good question. Yep, Haley said, go to feedback. Yep, the topic's there. Perfect. I love it when it works like it's supposed to. Any other questions?
Can you talk a little bit about what the next phase of that project entails now that we have our topics?
Yes, so the next phase will literally be just starting to get your research project topics. So I want to see just basically kind of like 5 sources. I mean, they don't even have to be things that you finally use for them, but literally just 5 sources in APA formatting. If you've never done APA formatting, the library has some great things. If you're researching through the library at Western, I want to say it even has a link to be like, okay, turn this into APA formatting. So it should be nice and easy there, but it's literally, okay, these are 5 topics or 5 sources that I'm going to get my information from to actually talk about in my research paper. So it's basically just saying, okay, if you've never done APA formatting, this is a good chance to kind of do it. That would be alphabetical order. you know, and whatnot there. So just kind of, you know, getting an idea. You don't have to end up using any of these topics in your final paper, but just to give you an idea of, okay, I'm trying to stay up with things here. And that's not due until September 30th. And I'm right with you. I'm actually in the process of helping write a textbook. So I'm right with you with the APA. If it's mind blowing and things like that, I get it. It's a pain, but it's professional. Question. I talked over somebody. I'm sorry.
I'm sorry. Oh, Dr. Johnson, I'm sorry. Where will we see the topic for the selection?
If you go under the feedback portion, it's right in the grades, I believe. If somebody could verify. So if you go under the grades, yeah. So there's a feedback section, and that's where it should show up.
Oh, I see. Okay. Oh, I see that you put that in. Okay. And so then what did you say, I'm sorry, was due on the 30th?
The part that's the 30th, which is right in the syllabus, that's I call it the first source submission. So I just want to see 5 sources that you may end up using. So you're going to go ahead and put that in APA formatting, and to get that actually put in, you'll put it on Microsoft Word or whatever program that you use, and then submit it to Dropbox. So nothing more than that. You don't have to put, if you want to put more information in there, great. You don't have to. And go from there.
Thank you.
You're welcome.
So the test will be over everything that we've learned so far from this point, right?
Yep.
Okay.
Yep. So it'll be just this module, exam 1 and 2, which, I mean, let's face it, that's a lot. So there's plenty of material to choose from. I try not to get too nitpicky. And I do try to be fair, so please know that.
I'm sorry, may I ask one more thing?
Of course.
With regard to the sources, they have to be all scholarly articles, correct?
That's ideally the goal there, yes.
Okay.
So, you can use the textbook. You can use, if we get to the point where, you're like, oh gosh, we talked about this in class, and, especially as we start getting into different eye diseases already, yeah, you can actually source some of my material as well. Totally fine.
Like for instance, for me, my topic is blast-related ocular trauma. So I'm going to be, obviously that's related to a large amount of that is research is coming from veterans. So I can cite VA, research.
Yes, absolutely. Oh God, yes.
Okay, thank you.
Any other questions?
Let's see, one more time, can you tell us what the types of questions are on the test?
Yes. So we're going to have 10 multiple choice,
Okay.
10 true and false, and there'll be 8 short answer.
Okay, cool. Thank you.
You are welcome. And thank you for making it fun. I don't know how fun the class is. You guys may think differently after exam 1. I hope not, but I do try to make it entertaining because I know this stuff can be pretty dry. So anyway, thank you for that. I do appreciate it.
No, I'm enjoying it. too. I never thought I was much of a eye geek, but it's really cool.
If you give it a chance, there is just the amount of information and what you guys will be doing for others to help them is absolutely incredible. It is so fulfilling. It's really cool. So, anything else for tonight? Alrighty, I am going to end this for tonight. I hope you all have a great week. For those that are going to hop on, I will see you all Friday evening at 8:30.
Hello, Professor.
Yes.
Hi, this is Raquel Reeves. I emailed you about something that I'm going to have to leave the campus because of a family emergency.
Oh my gosh, yes, I meant to respond. I'm so sorry.
hmm
Um,
Yeah.
I am so sorry about that. Let me,
hmm
whatever you need from me, just let me know.
hmm I was going to ask you, can you open up the topic from again? Because I didn't get a chance to do that. If it's possible, I don't know
Please
how.
just email me.
Just email you.
Yep,
Okay.
yep, absolutely. Just email me. Totally fine.
Okay, okay, and the introduction, I was able to get my intro in, but I wasn't able to reply to
Oh,
anyone.
that's totally okay. So,
It's okay.
yep,
Okay. Alrighty. So I'll email you the topic and everything.
perfect, perfect. Thank you.
You're welcome.
I'm
Oh,
sorry,
I'm
Dr. Johnson, the Friday night is review for the upcoming exam.
Yes, it's totally optional.
Okay, is that recorded or no?
Yes, that will be recorded.
And so the exam starts from the 21st to the
The 24th, yes.
so the 21st to the 24th.
Yep. So when you sit down, just make sure you have plenty of time to complete the entire part. Because if you go out of it, it submits it.
And it's only 40 minutes that you have?
Yes.
Okay.
Professor, I forgot to ask you something else. With accommodations, how do I do that? Because on tests, I get double time.
Yes. So with any of the accommodations, I actually
Mhm.
go through and personally put those all in
Okay.
whatever DSS sent me.
Okay. Alrighty.
Yeah, no,
Okay.
absolutely. Great question.
Okay. Alrighty. Well, thank you so much, Professor. Have a good
You're
night.
welcome. Thanks, you
Thank
too.
you very much, Dr. Johnson.
You're welcome.
Have a good night.
Thanks, you too. Alrighty. Good night, everyone.